welcome to the Premier Power Week. If this is your first session of the day, I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Premier Power Week is the second of two international live series that CPBF is hosting 2020 in recognition of World Prematurity Day. These education sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, Koehn, EFCNI, and GLANCE, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With educational sessions like this, we intend to bring you the guidance of healthcare professionals and the knowledge gathered by researchers around the world. These are valuable tools to help our community raise awareness and advocate for the well-being of families and their babies. I would like to thank AbbVie for the unrestricted educational grant and Pampers for supporting the Premier Power Week. And right now we're going to talk about the worldwide impact of COVID-19 on patient and family-centered care. Dr. Franck will share findings from an international survey of changes to hospital policies and practice regarding patient and family-centered care during the first wave of the COVID-19 pandemic and how hospitals engaged patient and family advisors in planning and implementing changes. Dr. and Professor Linda Franck holds the Jack and Elaine Koehn Endowed Chair in the Pediatric Nursing at the University of California, San Francisco, UCSF School of Nursing. She has extensive clinical research and academic experience in maternal, newborn, child, and adolescent healthcare, with a particular emphasis on improving patient and family partner healthcare delivery and research. From 2015 and 2020, she served as co-principal investigator and director of postnatal research for the UCSF Preterm Birth Initiative. In 2020, she was inducted into the Sigma Nursing Researcher Hall of Fame and named the UCSF School of Nursing Research Mentor of the Year. Dr. Linda Franck, thank you so much for joining us, and congratulations. It's so well deserved. Your work is phenomenal, and I'm so happy to bring you to share your knowledge and expertise with our community.
Thank you so much, Fabiana, and thank you to the Canadian Premature Baby Foundation for this opportunity to share some new research on the COVID-19 pandemic and impact on family-centered care. Let me go ahead and share my slides with you.
Absolutely, and we're just going to remind everyone watching us that we are having a Q&A time after your presentation. So you can send your questions and on the comments below.
Wonderful. So before I begin my remarks, I just want to acknowledge and thank the fantastic team who worked with me to complete this rapid research. Research doesn't happen just one person. So it was a large team effort with collaboration from colleagues at the Institute for Patient and Family-Centered Care, from the University of California, San Francisco, and the University of Washington. And we were supported by the UCSF Preterm Birth Initiative communications team. In the brief time we have, I'd like to review with you what we know about care and pandemics and share data on how hospitals have responded to the current COVID-19 crisis, and then discuss some evidence-based approaches to protecting patients, families, staff, and to preserving family-centered care. This slide will be a review for most people listening to this session, but it bears reminding ourselves of the core concepts of family-centered care. Dignity and respect, where families' knowledge, values, beliefs, and cultural backgrounds are incorporated into the planning and delivery of care. Information sharing, where families receive timely, complete, accurate information so that they can effectively participate in care and decision-making. Participation, where families are encouraged and supported in participating in care decisions and at the level that they choose. And finally, collaboration, where families, health practitioners, and healthcare leaders collaborate in all aspects of healthcare, including policy, implementation, research design, education, and more. Now, concerns about hospital provision of family-centered care during a global crisis are not new. In Liz Crocker and Bev Johnson's book, Privileged Presence, they describe the negative impacts of the 2002 to 2004 SARS epidemic on family-centered care. That we must pay attention to the side effects of separation of families from patients. IPFCC also published a white paper in 2010 with lessons learned from the SARS-1 and outlining steps that healthcare organizations should take in planning for the pandemic. They advise that it's important to take steps to contain the illness and to remember that family members are stewards of patient safety and integral to a patient's well-being. However, not everyone has listened. For example, when the first COVID surge hit the US in the spring of 2020, hospitals such as a major New York academic medical closed their doors to all family and support persons in the name of safety. In this instance, a national outcry followed on social media and press, and about 2 weeks later, the New York governor issued a reversal of policy. A month later, WHO clarified their guidance specific to newborn care and recommending to protect practices of skin-to-skin contact and breastfeeding. Then other groups like the American Academy of Pediatrics, the Royal College of Pediatrics and Child Health, and the British Association of Perinatal Medicine, to name just a few, all followed suit, recommending non-separation of newborns and mothers in all but the most extreme circumstances. Parent advocacy organizations have also been very vocal about the harm being done, treating parents of newborns as visitors banned from hospitals. But concern about overly restrictive hospital policies have persisted, and we've heard many stories from around the world of parents being unnecessarily separated from their newborns because of fears about the COVID-19 transmission. But it's hard to combat misinformation or promote best practices when so little information is available about what is happening on the front lines. So my colleagues and I quickly designed a survey to gather information about family presence in hospitals and to learn how hospitals were partnering with patients and families in changing and implementing new policies. Our methods were simple: an online survey posted from May 8th through July 31st. We conducted outreach via websites, professional groups, and targeted emails to hospital contacts. Respondents could report on hospital-wide policies and practices or for specific patient care settings. I'd like to share some of these results with you now so that you can use the findings to prevent further collateral damage to family-centered care in your settings. So what did we find? By the closing date, we received responses from 541 individuals representing a range of roles within 394 unique hospitals and health systems and 35 countries, although the majority were from North America. Almost all the respondents reported hospital policy changes that limited the presence of family or support persons due to COVID-19. We asked how many support persons were permitted at a patient's bedside by setting. As you can see, most of the adult settings were not permitting any support persons to accompany patients. The maternity care and pediatric settings predominantly allowed one support person with the patient, and some of the neonatal and pediatric settings permitted two support persons. We also asked how patient and family advisory councils, or PFACs, or patient and family advisors were involved in the COVID-19 policy changes. Respondents reported a low level of involvement, with around 20% involving them in planning and communication activities. Now let's take a closer look at selected responses from the neonatal and pediatric settings. In this question, we asked how COVID-19 policy changes impacted the 4 domains of patient and family care. You can see that just about 20% of the units reported negative effects of the COVID-19 policies on their ability to provide respectful and dignified care, and reported it was improved, whereas 40% said that the policies had negatively affected information sharing. The majority of units reported negative impact on patient and family participation in care planning and on patient and family support related to the COVID-19 policy changes. There were some small differences in the proportions across the pediatric settings, but they may not be significant. We asked if common interactions between the clinical care team and families had changed because of COVID-19 policies, and indeed they had. The most common being in medical rounds and transition planning. It's quite a bit more difficult to practice shared decision-making or transition planning if families aren't able to be present. We also asked a specific question about the impact on healthcare disparities, and here you can see that 50% of the NICUs and PICUs reported a negative impact. This was in contrast to the pediatric units. We also asked a series of questions about what had been put in place to support family members during the pandemics. For those whose families members were permitted to be present, most of the sites, but by no means all, provided personal protective equipment or PPE. About half or less provided access to free meals or subsidized meals, transportation, or overnight accommodation. But the number of NICUs providing these services was notably less than the other pediatric settings. We must ask ourselves and our hospital administrator colleagues why this must be so, when the need for proper nutrition and proximity to the infant is essential for breastfeeding, for example. Notably, mental health services were more often available for NICU support persons, but the numbers of sites reporting this were small. For family members who were not permitted or who weren't able to be with their baby, about 60% of the sites encouraged the use of technology. About a third offered or encouraged the use of specific software or apps, with access to support staff such as a family liaison. Fewer loaned devices to families, and only a few provided guidance on how to keep devices clean. This was a surprise. Again, there were only small differences in access to these supports by unit type. Additionally, family members who were not permitted or who weren't able to be with their child were offered the possibility of participating remotely in rounds in about 30% of, they were not permitted to participate in rounds. In about 50% of the PICUs and 60% of the NICUs and PICUs also made daily calls to non-present parents. Fewer sites provided the option of remote family meetings or assisted in helping families with access to video calls with their ill child or parent. And again, mental health services were rarely provided. In summary, this very brief snapshot of the first wave of the COVID-19 hospital policy impact on family-centered care shows that hospital leaders and care providers believe that family-centered care has been negatively impacted. And for neonatal and pediatric units, the impact has been most profound in reducing family support and participation in care planning and in widening disparities in care. We found substantial variation in policy and practice across settings and variable efforts to mitigate the impact of the restrictions. And disappointingly, patient and family advisors have played a very small role in hospital policy change and in communication. Now, I just want to share with you another new study that includes 4 NICUs in the UK and 2 in the US that documents the impact of COVID-19 related restrictions on family presence on parents of sick newborns. This chart shows the impact on key aspects of parental involvement based on the approach to the restricted access. Overall, having one parent with unrestricted access had slightly less impact than the other approaches. However, the engagement of the partner suffered even with this approach. Unfortunately, the study does not provide any data on the effectiveness of the restrictions. So were there any exposures caused by maintaining parental contact, or prevented by the differential restrictions. We don't know this. And this crucial data is needed if science-based rather than fear-based policies. This slide shows a couple of the quotes from the parents who were restricted from being with their babies. I think these quotes capture the impact much better than the numbers do. One parent said, "It felt like my baby was not mine and I was asking permission from the nurses. Also, it has made me feel resentful towards my husband as the emotional burden of a child in the NICU fell upon myself." Another parent said, "I will remember this for the rest of my life. I will also remember the kindness of the staff, but at 18 hours old, I was told my baby might die and I had to beg to see him because I'd already had my 2 hours. How is that okay?" I think we have to ask ourselves, how is that okay? Although the results of our survey or the survey from the UK that I just shared with you may not surprise you, they are a call to action. Your powerful voices are needed to advocate for more rational health promoting policies, and I hope you'll visit our website and review these initial results in more detail and use them as motivation to re-examine your own policies and practices. We have posted a link to register your unit or your hospital to take part in future surveys and interviews, and I hope you'll help us share this link widely and help recruit many more units and hospitals to register and participate. It's clear that the response to the COVID-19 pandemic so far has been fear-based, creating false choices between the best interests of the population and of individual families and family-centered care, treating families as members as visitors against which staff need to be protected. A more rational or evidence-based approach to the pandemic calls for families to be included as allies and partners in caregiving, provided with education, support and PPE, just like staff, treated as respected members of the healthcare team who provide essential emotional and physical support to patients, and recognized for their contributions that they make to patient and staff safety, as well as emotional well-being. As Dr. Martha Curley and colleagues have stated, infection control, public health concerns, and family-centered care can coexist. As the pandemic continues, we must update policies to ensure that hospitals and units practice shared decision-making for every aspect of care and in determining the necessary restrictions, and that they increase support to mitigate the stress contagion for families and healthcare professionals. If we fully accept that there should be zero separation between infants and parents, then we can put our collective energies to finding effective solutions. For example, creative use of space and transitioning members of the healthcare team to remote working via technology so that we can preserve the parental presence with the babies while lowering the overall occupancy and traffic through the neonatal unit. Using technology to support the connection and developmental care, such as in the middle photo, this Zoom music therapy class, where babies get to see an unmasked face over the Zoom, and the parent is at the bedside being guided by the remote music therapist in developmentally supportive activities with their baby. And then, as shown in the last panel, providing and investing in education and support for parents so that they have the knowledge and skills to be true partners in infection control and safety. On this slide, I have listed some sites to watch for up-to-date guidance on family-centered care as the pandemic evolves. COVID-19 pandemic has caused much direct suffering. It's also resulted in disruption of the global economy and a chain reaction of adverse effects, particularly for more vulnerable populations. It's easy to get discouraged by the enormity of the devastation caused by the virus. But let's not cause more collateral damage by giving up hard-won progress in humane, science-based way of delivering healthcare, family-centered care. In fact, we should be doubling down on what we know works. Families are not the virus, or to be feared in the fight against the virus. Families are working together. We can, with families, we can help protect vulnerable children and staff from the virus. Families are a shield and a protection that we must really employ. Let's work creatively together with families towards our common goal of safety and quality of neonatal care. Thanks for listening.
Wow, Dr. Franck, thank you so much for this presentation. It is absolutely heartbreaking to see the numbers, to hear the stories, to read the quotes. And right after your talk, I have a mother who actually experienced the NICU in the very beginning of the pandemic, and it's absolutely heartbreaking. And when I talked to her the first time, I actually cried because I could not put myself in her shoes to imagine what that looks like, to be away from your family for so long, and you had to make a choice between your husband, your other children, and your baby in the ICU. So thank you for the work that you're doing. I really hope this will shine a light in many hospitals to look into their policies and protocols now that we are right in the second wave of this pandemic. So my first question to you is, how do you see FICARE or family-centered care moving forward?
Thank you, Fabienne. If I had a magic wand, I would wave it and make sure that I think at the very least that patients and families are involved in decision-making around restrictions and in policies and in communication around policies. I think that's the very least we can do. Many hospitals made huge progress over the last decade in engaging families, not just in the care of their loved one, but in the operations of the hospital and advising on all hospital policies and practices. And I think that is something that's easily maintained. It can be done virtually, it can be done, asynchronously. And so I think at the very least, we must engage families in decision-making and in planning around the response to the pandemic. Beyond that and alongside that, I think we must preserve and fight for zero separation of infants and newborns and children and their parents. And I think that is hopefully, I caught the end of Nicole's talk, and she mentioned about how, maybe because of this, we come out stronger in recognizing the importance. Now that we've had a period where, unfortunately, there have been some, receding of the progress that has been made, it will help us recognize how critical it is, and we will return to those practices with even more commitment.
So my question to you is: are we taking notes of the situation, what happening with families not being included, family advisors not being heard? Because as you mentioned, there was papers published from SARS pandemic, lessons learned, how can we prepare for the next pandemic? And obviously that did not happen. Are we learning lessons now as a healthcare system worldwide to not to see this happening again?
I think that is critical, and this is an area where we can all participate. We must gather the data around the impact, what collateral damage is happening, what are the adverse effects. We must all contribute. So I encourage hospital members listening to these presentations to join our survey so that we can create a registry of hospital practices and policies. I know there are efforts where parent advocacy groups, I believe led by the EFCNI, and I know Canadian Premature Baby Foundation is a huge collaborator in collecting parent stories and data from parents directly around the impact on them. So I encourage everyone to join together to help make this visible. What's not measured does not get seen. And so we need to measure and share the effects that we're seeing and make sure that they are looked at with equal weight as we look at the restrictive policies.
Absolutely. So I want to share with you that last week, one of the family advisors here in Canada called me, and she was in absolute tears that families, only one parent has been allowed in her unit to stay with the baby. And even in times of palliative care, the parents could not be together in that moment. So how can we, in the middle of this pandemic where the protocols are still in place, the restrictions are still in place, can you possibly convince or show the numbers, show what is happening to change some policies, or at least have some compassion in moments of life and death? to make that situation a little bit different for families?
Yeah, I think and maybe, collaborating beyond our usual networks to talk with others who have been successful in creating large scale change or in marketing, for example, to really, again, we have to deal with the fear that is in the population, the fear that is in hospital administrators, and help them see that that families are allies and not to be feared, that they are there to help and protect, and that they have the same goals. Some of this is very difficult to do in the middle of a crisis, but I think there are techniques that we can learn from other examples and in other settings. I think one, you mentioned compassion. Compassion is really important, and figuring out processes where there can be compassionate exceptions if people are not willing to make larger scale changes on the rules as a whole, and our negotiation skills. I think we have to, continue to hone them. So reaching out beyond our usual networks to get allies in this fight.
Absolutely. And there are so many people around the world right now advocating, and together we can certainly be stronger and raise the voices of these very vulnerable families. So we have a few comments here I want to share with you. Dr. Carol Bryant said she loved the quote, "The family is not the virus." We have a comment from Monica Virtus, who runs a parent organization in Madrid, Spain. Very nice presentation, Dr. Franck. Parent and families are so important. We also have a viewer from Kamloops in BC who wants to have access to a presentation after. We will have the presentations available on our YouTube channel and website very shortly. So I want to ask about technology, because obviously you're from San Francisco. First time I went to your hospital, it was the first time I saw Zoom 3 years ago. And you're always ahead of the game in technology. But many other hospitals are still implementing technology. It's new. During the pandemic, there was this rush to get technology into the ICU. And you really, you pointed out that it's not to substitute parents, it's really to enhance. And how else can we connect the families and use the technology in that way to enhance that connectivity? So I want you to leave this message very, very clear for all the hospitals who are implementing technology, that this is not an or thing, but is an and thing.
Yes, well, I think you said it well, but I'll just say it again for reinforcement, that that having a parent being connected virtually is not the same as having them in the unit providing skin-to-skin care, breastfeeding support, emotional support, developmental care with their infant. So it's not the same, but it can be used to enhance. And for example, where we're not able to make progress with both parents being with the baby, perhaps making sure that the second parent or partner, a support person, is able to attend rounds, for example, and hear about the care decisions being made and have input into those in real time. So I think remote access with technology for engaging with the healthcare team around decision making is, a wonderful enhancement. And I think one of the, if small silver linings of the pandemics is the liberalization of use of technology, and so that we can increase access for parents who had difficult access for things like rounds. And I think the developmental care and the ability for babies, particularly the older babies who are in the unit for many, many months, say over 4 months old, up to a year old, and children on pediatric wards, the young children, being able to see an unmasked face more often, even if it's through video, might be something that is beneficial. Being able to have the staff remotely, for example, the therapist and other people who can coach and help support parents. So preserving the space at the bedside for the parent, and having the staff who are the teachers and coaches be the remote person guiding the parent in the interaction with their baby. Those, I think, are some of the creative and important uses of technology. But it is not, as you said, a substitute for parental presence and participation in the infant's care.
Absolutely. Are we going to do a follow-up survey next spring?
We are going to do a follow-up survey as soon as we can figure out how to organize ourselves and get some funding. But yes, we will hopefully do that at least by next spring. So I encourage everyone to go to our website and register your interest. Unfortunately, there are no, accurate lists of hospital NICUs and units and contact people for us to easily send out the surveys to and make sure we have good representation. So we're counting on you to sign yourselves up, and so that we have you on our list, and we will, as soon as we can, try to update the data and see how the practices are changing and trending, and post that information publicly so you can continue to use it for your own advocacy efforts. Thank you.
Okay, Dr. Linda Franck, thank you so much for joining us here today. I'm so grateful to have you sharing your knowledge and expertise with us today. Thank you.
Well, it's been a pleasure, and thank you everyone for all that you do, especially Fabiana and the Canadian Premature Baby Foundation.